Good afternoon, and welcome to today's talk in the Hot Topic series by Amar Gupta. I'm Randall Davis, and I'll be acting as the host for the talk. Our speaker today, as I said, is Amar Gupta. He spent most of his career fostering innovative technologies and processes, and then, importantly, helping with their deployment on a global scale. He was at MIT earlier as a principal research scientist and senior research scientist. He then left Boston to serve as an endowed and tenured professor at two different universities. He eventually came back to MIT in 2015. He has been a founding associate editor of IEEE Transactions on Internet Technology, associate editor of IEEE Transaction on Industrial Electronics. He's published over 70 papers with the largest subset in computer science journals. He served as an advisor to the World Health Organization, as well as a number of major corporations. At MIT, he's developed and taught the course on telehealth and telemedicine for global health. For those of you keeping score, it was co-listed as 6.884. And in the meantime, let me welcome Dr. Amar Gupta.
Thank you very much, Randy. Thanks for the very kind words. And also good afternoon to everyone else. Let's get started with the talk this afternoon. And so the first thing I wanted to tell you is that over the last month, 6 weeks in fact, I've been receiving unprecedented amount of mail, calls and all regarding telehealth. So one of the things which has happened with COVID-19 is the fact that suddenly there's a lot more interest in this field and one needs to find out what's happening, what's going on, what we can do in it. So it's a great time to think of the kinds of ideas which we had, which earlier we couldn't proceed forward with it. I'm going to start with two different anecdotes which really shaped my work in this area. The first one is an accident which took place on the Mexican side in Arizona. At that time, I was an endowed professor in Arizona. And in this car accident, all the 6 adults died on the spot. There was only one baby who was left with very serious injuries. The baby was driven across the border to a remote clinic in Arizona. And the doctor on duty was new to the job. In fact, it was, as I read from some versions, it was her first duty on the job. So she didn't know what to do. The good thing which was there is that Arizona was one of the first states to start the notion of tele-trauma centers, which is that in the rural areas, there would be a center which is connected by technology to an urban center. And as we look around the country, the chances of survival in the rural areas are only 50% of the corresponding figure for urban areas. And it was really innovative that Arizona had gone ahead and made this particular. Now, as I was talking with the doctor who had saved this baby's life from far, giving the instructions to the rural doctor, my immediate question was that you're doing such a great job in Arizona. How about making it for the rest of the country? How about going nationwide? And he told me it would be illegal to make it nationwide. And I was totally surprised and shocked. I didn't know what was happening. And he says he didn't know all the facts, but that is a reality. They couldn't do these things across state boundary lines. So I went ahead and started reading the literature, found that there was a company called MyDoc.com. It was a subsidiary of Roche Pharmaceuticals. So obviously they had a lot of cloud, a lot of money, a lot of legal help and all. And they had started this company called MyDoc.com by which patients in Chicago could consult a doctor through electronic means. The doctor was based in Indiana. The patients were very happy. They were getting good surveys. The doctors in Indiana were very happy, but the doctors in Illinois were very upset at it. And they got this company closed down on the premise that is illegal to do anything with respect to a patient unless you're seeing the patient face to face. There was nothing in the laws of Illinois which required that, but that's how it was gone ahead and interpreted. I talked to my colleagues there in different schools, medicine, law, others. None of them were interested in getting into this issue. I felt really challenged that somebody ought to really stand up and do it. So over the next few years, we did a lot of work. We found that states had gone ahead and prohibited the practice of telemedicine across state boundary lines. And as I did work further, I co-opted a second-year law student to work with me. And we produced a number of papers. And basically, these papers said that all the restrictions imposed by state governments on interstate practice of telemedicine, they violate the Interstate Commerce Clause of the US Constitution. And therefore, all these laws are illegal and inapplicable. It was a very bold assertion. I showed the paper to a lot of friends, lawyers and all. I told them to rip that paper apart. All of them said it was sound. I invited them to be co-authors. They said it was too controversial a topic. So basically, this paper was just published with my name and the name of that student. The other anecdote I'd like to mention is this is a real case again. Uh, a husband and a wife go to California. The husband is getting a new job as an endowed professor. The wife falls backwards in the Marriott hotel there. She's taken by ambulance to the Kaiser Permanente hospital. And at Kaiser Permanente, they look her and they say, well, we only take care of Kaiser patients. You're not a Kaiser patient, therefore we have to send you somewhere else. They spend the next 4 hours trying to send to somebody else. None of the other hospitals will take that person because it's actually a violation of law to transfer somebody like this in an emergency. Finally, the hospital turns around and directs the family to go to Boston and get the service done, fly 2,600 miles. The person was totally helpless, couldn't do anything. The emergency surgery took place 10 days later. And by the way, I happen to be the husband of the person, of the couple who's involved in this process. In contrast, one of my close friends, he's working at the elite university on the West Coast. He had a similar experience. He went to Switzerland, he had it, and within half an hour, he was on the surgery table and they took care of it right away. So these are some of the things which we find. And by the way, the hospital at which we had gone is a part of a chain of hospitals which claim to be one of the leaders in telemedicine and telehealth at this point. So it's just ironical how the way they react and how the business processes dominate in these cases. Let me tell you what's happened since then. In 2017, the director of telemedicine of the Department of Veterans Affairs came and visited us at CSAIL. He said this was the most authoritative piece of literature which he had seen on this issue. He had a long discussion with me, spent a lot of hours. And as I was driving him to the airport in the evening, late at night, he wanted to spend as much time with me as possible. He said, you're not a lobbyist, you've done a thorough job, you've answered all my questions. I'm going to go ahead and take the next step. And within a few months, the Department of Veterans Affairs announced their new nationwide policy, which basically said all the state boundaries will be disregarded in order to practice across state boundary lines. And by the way, the Department of Veterans Affairs, the money that is spent just on transportation alone of veterans to and from hospital facilities, that is in excess of $1 billion a year. So just imagine how much money can be saved if these people don't have to travel and other patients don't have to travel. The irony, however, is how this thing was the reactions I got on this particular development. First of all, when I was in Arizona, the people around said, well, I belong to a particular college and a particular department. I was not allowed to take a research assistant from a different college. And I said, what is this going on? And they said, it's never been done in the past and we're not going to do it. And finally, I persuaded them to do it. When this policy was changed by the VA, I received a lot of messages of congratulations. But one of my own colleagues at MIT walks up to me and says, Amar, why did you waste your time on this? A lawyer could have done this work in less than half a day. I was feeling bad, but 2 weeks later, I go to a conference at one of the elite universities in New England, which has a medical school, a law school, business school, engineering school, all of the ones you can think of. I run into a doctor who's both a doctor as a lawyer at the same time. I talked to him about interdisciplinary work, and he says, yes, absolutely, interdisciplinary work should be done. All doctors should have a law degree. And I said, well, what do you think about information technology? Oh, we don't need those guys. Even a high school student can write a program these days. Why do we need anybody else? So this is the kind of wave that we react when we see people from another field trying to work on these kinds of issues. And therefore, the range of reactions I've gotten are all over the spectrum, from people who think it was great work to people who feel, why did I do that work in the first place? And after that, we have tried to work with other agencies. I was invited to Washington to give a keynote address to federal officers in a closed door session for senior federal officers. And before that, I wrote to people around in the US and other countries about what one thing that they should tell me, what I can ask in Washington. From the other countries, I got very good suggestions. From the US, except for one suggestion, all the others are related to the fact that please go ahead and get reimbursement for this new process that I've developed. The government still doesn't reimburse it. That's what you should go ahead and get it cleared from them. That is the urgency. So again, I think the motivations are different. The incentives are different. One is to deal with it. We have been working in this area of trying to extend this concept that VA has to other agencies. And suddenly what we find is that COVID has done all this work for us. Immediately, all of them have done it. Some of the emergency guidelines are poorly drafted. There are mistakes in them. I remember I get a call from a doctor in Maine, and he said he had spoken in my class at MIT, and he says, I'm confused. The people in Washington are saying that I can go ahead and do it, and I don't have to worry about HIPAA and other things. And my lawyer is saying you can't do it. What do you think? And I told him, I think both are right. And he says, what is that supposed to mean? I said, normally when there's a federal law and a state law, the federal law trumps the state law. That's the terminology which has historically been used, that it dominates. In the case of privacy, they made the opposite regulations that you have to follow both the federal laws and the state laws. And in case there's a conflict, whichever gives more rights to the privacy, more, that should be the one which will dominate over the other. So basically, the federal government has said that HIPAA they want to regulate, but the states have not said anything. So technically, they can go ahead and after you that you've done it, and states have all kinds of regulations. One state wants that all telemedicine encounters should be video recorded and kept for 3 years. Another says that if a person from that state goes to any other place in the world, including a foreign country, the HIPAA regulations of that state will apply. So we still have this dichotomy, which has still not been resolved. In emergency, people are overseeing these things, but these are the issues which will come and bite us after it's done. Again, I find that in the area of telemedicine and telehealth, the foreign countries which are far ahead of what's happening in the US. There's one country in which if a person gets cancer, you're automatically eligible to send all your records through email to the best cancer specialist in the country at no charge to you, get your response really quickly. So I've seen it both in the US as well as abroad, and also I've been involved. When I was dean in New York, I actually worked with the local community to set up the telehealth intervention program for seniors. Initially, everybody was very skeptical, the government officials, the industry and all, we had to raise money for it. And within 3 months of the inception of the program, the number of calls for ambulance is reduced by 75% just in 3 months' time. And that center is now being used to look after people in quarantine, both the seniors as well as others. And so we have seen a spectrum of it, and I'm going to take some of these examples as we go along. One of the things which I still debate is where will the US stand as far as when all this COVID-19 thing is over, where will it stand? And just for your record, I should tell you that if you take different statistics, and here I'm using the word from the CIA, in terms of infant mortality, historically, the US was ranked 49th in the world. And I looked after this thing 10 years later, and I found that thing has changed. Instead of the 5.98, it has actually become 5.80. It's improved. But on the other hand, its ranking has actually dropped from 49 to 56. So time will tell where we stand, and other statistics also like longevity and all. We've still a long way to go, and again, we have to see what can be done. And I feel a lot of these things can be taken care of if we allow telemedicine and telehealth to be used much more vigorously and much more extensively in the country. Now, one of the things I wanted to say, and this also relates to the topic of my talk itself, is that based on my experience, both in the US as well as in other countries where I've gone on emergency basis and otherwise, and I feel that all organizations go through 4 stages of evolution. Whether it's a startup, whether it's a company, whether it's a country, whether it's an empire. The first stage, you basically say, get the work done, don't worry about rules, don't worry about factors, don't worry about how many people you kill. That's how empires are set up in the first stage. We just won the territory. The second stage is get the work done, but also try to follow the rules to the extent possible, minimize the casualties, don't kill more people than is necessary. That's the second stage. In the third stage, it is that try to get the work done, try harder to follow the rules, minimize casualties, and also we have set up internal rules and regulations beside the external ones, and therefore you should follow them as well. And the fourth stage is just go ahead and follow the rules and procedures. Don't worry whether the work has gotten done or not. And that's what I increasingly find happens in a number of cases where people just want the status quo to continue. And I'll give you 2 examples. One is of a major empire which existed before the First World War and basically collapsed in the First World War. And the reason it collapsed had nothing to do, in my opinion, to the First World War. The reason it collapsed is the internal forces which were there. The police in that country was corrupt. So basically, they started a second system of police to oversee the first level of police. The second system was also corrupt. So they went ahead and started a third layer and a fourth layer. And increasingly, the corruption level increased. The person who was there on the street had to pay much more bribes and much more. And that's what really happens in situations like this when we don't have anybody to guide it, to change it. And the same thing happened in my case when I tried to go to the agencies which were supposed to be responsible for patient dumping, they basically said, we'll take very good action. This is really a serious matter. We'll do it. And later on, they basically said to me, no, we are not going to do any study because you complained to the hospital and the hospital has responded to your with a letter. And what does the letter say? The letter says, we think we did what was supposed to be done. If you're not satisfied, go to a small claims court. That's what they sent me in writing. So basically, they're saying spend $2,000-3,000 going to California, filing a small claims court, and then if you're lucky, you can do it and just get out of it. And that's what is happening in situations like this. And by the way, the same federal agency, at the same time when I was going through, they went go ahead and invite me to be one of the members of their new committee on sepsis, saying it's a great honor. They also say that we don't have any money. You'll have to come here for free, attend our meetings and all, contribute to it. And those are the same agencies today which are spending so much money on COVID and all. That's basically the forces of the status quo which have prevailed to a large extent in this industry. And that's what I'm trying to talk about, what new opportunity has been created because of COVID at this point. Let me give you a previous example and tell you why I feel that we have a rare opportunity today. And the example I'm going to take is from the financial industry. I find a lot of similarities between the healthcare industry and the financial industry. Both deal with a lot of data. In both cases, the costs are important. Both have issues of privacy and security. Both have been traditionally bound by state law regulations rather than federal regulations. In the US, a bank was only allowed to operate in one state of the country. Citibank in New York, for example, Bank of America in California. So the problem first arises when they have to process checks. And the easiest thing the government could have done is to allow the banks to have branches across state boundary lines, but that's not what they do. They say anytime a check is out of state, we will help you clear the check for you. So for 8 years, when I was an endowed professor in Arizona and was there in the stayed there in the winters, in summers I was at MIT, I still had my Boston checkbook. I would write a check. The checks for Tucson would go by a truck to the designated branch of the Federal Reserve Board, which happens to be in Sacramento, California. Then it would go by an air courier to Boston. Then it would go to the lead bank, and then it will be given to the local bank. For this whole transition to take place, physical movement and all, the cost of processing one check to society was $1.25. And 44 billion checks were processed in this manner every year in the US alone. And the same problem was there in other countries. In Switzerland, for example, there was only one check processing center. Every check had to physically come to that site. So my group at MIT, they developed new technology for reading the checks with very high speed and accuracy. In the US, checks are written in many different styles, especially the ones like 26 over 100 here. It's very, very difficult to read. My students suggested that we disregard the send portion, but that was not acceptable to the bank. So we developed the technology to do it. We went ahead and went to a lot of banking associated meetings, tried to convince them that they can use the internet to do it. The paper checks don't have to be done. Again, we were getting nowhere. So finally, I had to start this work in a foreign country, in a small Asian country, which really appreciated it, went ahead and accepted this thing, put it in place. And then one of the sponsor companies of this work on check processing was a British bank, National Vista Bank. And they liked the idea, and they went ahead and talked to people in the British government. And in Britain, the interesting thing is that the pence is written in the same size as the pound, so that makes it easier. On the other hand, in England, a check, it only says it has to be in written form. It doesn't say it has to be written on paper. And there was a fairly recent example at that time where a person wrote the check on a side of a sheet, and the banks had to honor the check because it was in written form. So we came up with specifications what the folks there should do, and within about 6 months' time, they ratified it, went ahead, and that became the national standard for checks in that country. In the US, nothing would move. I tried my best, and then we found that the banks are actually earning interest while the check is being transmitted. So even though the banks are saying we want your check to be cleared as soon as possible, they really want it to take as long as possible because they really benefit from it. It was going nowhere. We put our technology on it, on the web, still nobody would take it. And things changed radically around because of 9/11. Suddenly, where I was going nowhere, they immediately came. Within a few days, they went ahead and implemented the system. And the reason it happened is because all the planes were grounded, the checks was not able to be transported, and $50 billion of checks got stuck in a few days, and that's why everything moved like clockwork at that point in time. So on one side, an event like 9/11 is bad, hurts a lot of people. An event like COVID is bad. But on the other side, it also gives a rare opportunity which we don't otherwise have. And that's what I think is happening with respect to telehealth and telemedicine at this point. And therefore, all the startups coming out from MIT, or the CS people developing all these new technologies. Now is the time to really strive and see what can be done, how it should be done, and how you can really benefit the human race with it. At the time when we did this check processing work, we tried to get the medical community engaged. Um, I talked to the CEO of one of the largest health insurance companies in the country. He actually came and visited my lab, and he looked at the demonstration and he said he has two concerns with what we have done. The first concern he said, you demonstrated in the lab here, will it work in real practice? I don't know about it. And I said, I don't know either. We are in the business of creating the Wright brothers plane. The Wright brothers plane demonstrated that a person can fly in a plane, but they didn't fly in a commercial, they didn't run a commercial airlines. Similarly, we don't know how it will work in real practice. I can't give you. And his answer was I was astonished by his answer. He says, well, it doesn't matter if it doesn't work. That's okay. We spend money on it. What I really worry about is if it works. If it works, then I'll have to use it. I'm the only honest constituency in the whole healthcare ecosystem. A lot of others get a lot higher percentage of profit. I work on less than a percentage of profit. If this works, then I'll have to change the whole system. I'll have to fire people. I'll have to go ahead. And that is really a problem. That's what I don't want to do. They would thank you. We don't want to deal with this, and we don't want you to do any work for us in terms of medical. That's the response which I got at that time. And that's been reiterated to me at a number of different times with different agencies and different people, that status quo is fine. As it is, the status quo is difficult to manage. Don't complicate our work. Don't try to do any change. We use our technology to develop for reading mammograms. In the case of mammograms, when a single radiologist sees it, there's a fair incidence of false positive and false negative. We developed this technology. We were able to get much higher rates using the human being and the computer-based system together. Again, we run into the same problem that people say, well, it's there, do it for free. Nobody reimburses it, therefore we can't give you any money. We did get some seed money at the beginning. The seed money basically said, put conditions on it that within this time you should find a customer, a willing customer. And at that time, we were only looking at the US scene. We were not looking at the foreign scene. We may have felt differently, just as in the case of check processing. I went to a foreign one, because in the US system, it's a different way. In some other countries, there's a dual system where the government has a baseline healthcare system, but there's a private industry which is also around it. And therefore, we could go to the private industry, but that option we didn't consider, and it was also not valid that much at that point in time, so much as it's today. So about 20 years ago, around that same time when I was working on this mammography area, I worked with three eminent doctors. Two of them are endowed professors of Harvard Medical School. One is was the dean and endowed professor in Arizona. And we came up with this approach called the three-pronged approach to healthcare. The three-pronged meaning that there will be some people, or there are some people in physical proximity to the patient. It could be a medical technician, it could be a nurse practitioner, it could be a family member. Then there will be offsite people who are the medical domain experts, who may be in another city, another county, another state, another country. And the third will be the computer-based AI, data mining, other kinds of things, which is all done on an offsite basis. And the definition that we took for telemedicine and telehealth at that point is that as long as you have two of these three prongs, you fall into the category of telehealth, which is a little broader than what people have generally been using now. We take into account that all this thing which is done remotely through AI and data mining, that also falls in the category of the three-pronged approach. So the coronavirus pandemic has led to greater interest in it. It's being used in a number of places. These number of places, I can tell you from my experience, I'm editor-in-chief of one of the journals of telehealth. Number of countries are much more advanced in how they're using it for different purposes. Today, we find that hospitals are using the system and doctors are using the system to take care of coronavirus patients for diagnosis purposes while they go to treatment, as well as the end of it in terms of taking care of them while they've been discharged from the hospital or when they've died. And in each of these areas, I'll give specific examples at the end of it. I'm going to break at this point very briefly for a brief poll about telemedicine and telehealth. So I request Jillian to go ahead and post the poll at this point. Thank you, Jillian. There are 4 questions. If you can kindly answer them in the next 2 minutes, don't have to spend much time on it. They're fairly simple and straightforward. Okay, let's go ahead and go through your answers. On the first question, the answer which has been given by the largest number of people is telehealth has been developed after 2000. 38% of them of you have said it's developed after 2000. The reality is the answer to this question is 0. The first example of telehealth is exactly in the same year in which Alexander Graham Bell got the patent. He was on the Boston side. His assistant was on Main Street in Cambridge, right where Polaroid is located, adjoining building to it. His assistant spilled acid on himself, and Alexander Graham Bell told him what to do for the acid, how to take care of it. That's the first recorded example of telehealth. And it's grown by leaps and bounds much before 2000. It's only here that we find that recent developments have taken place, it's been in existence. In fact, there's a system which was done way back in 1970, where at the airport they installed telemedicine, and if you were a person, a traveler or an airline person, you could be seen there by people at MGH. Second one, in terms of the next one, the answer is actually 0 again. It took place right here in Cambridge. The bulk of you have said yes, 63% have said. The third question is interesting, which state is top. Massachusetts is actually the top. It's actually in the top 10%, and the bulk of you have said it's 60, that it's true. And the last one is surprising. The bulk of you say that the Massachusetts is among the top list, and actually it's in the bottom tier. It's in the lowest 10% of the states in terms of use of telemedicine until recently. So that's what is the reality of the situation, that innovation is going on, but deployment, we are really behind the world, and we are behind even the western parts of the country. That is the most advanced states in terms of using telemedicine today or telehealth are Alaska, Hawaii, and Arizona, and and we can come later for why that is true. Okay, let's continue with our presentation, and this is more with the CS people in view. What really should be done with respect to CS and what can be done about it. So if we are going to develop a digital health ecosystem, we have to take care of 4 different aspects. Having isolated companies work on it, that becomes very difficult to do it. We really need to have a real ecosystem where different kinds of functionality are available through the same network. We don't have to go and we use one package for one thing. And I can tell you, when we were doing character recognition, we had the same problem that suppose 4 was not being recognized with that much accuracy as others. My team went ahead and designed something for 4 alone. That worked beautifully for 4, but when we integrated with the whole system, it actually worked worse. The accuracy actually came down because it distorted the thing. So we actually came to the conclusion that doing these peak means kind of thing really doesn't work properly. And the same thing I feel for it, that if we need an ecosystem, which is a digital one, we have to have much better linkages between the different islands which exist today. And I'm going to go over this list with you. First of all is the aspect of knowledge acquisition, getting as much information as is available, whether it's on paper, whether it's on books, whether it's on people, however we want to do it. And what we find there is that in the literature, we have such conflicting facts which are there, articles which are there, and basically the doctor is helping us navigate through these conflicting articles to do it. We see it in the recent coronavirus pandemic also, how much conflicting information that we are getting. So just by aggregating raw information, we are not going to get a super knowledge base or anything like that. A lot of people will have to spend time in filtering this information, making it correct, making it to the level where different levels of people can do it. An expert in the field versus a primary care physician versus a nurse practitioner versus another healthcare professional versus the patient. Those are the kinds of things which will be required. The second area is knowledge discovery. We have people who have come up that they have found new ways of going through the data, analyzing it based on symptoms, coming on it. And here is where I would like to give you an example. When we developed this work on check processing, number of organizations got interested in our work. From one of the largest drug distributors in the country, we got a challenge problem. And the challenge problem was that some of our drugs are bought very rarely at rural stores. Some of them are only bought once a year. We'll give you data for the last 5 years. Tell us when the next drug purchase is going to take place. I gave this problem to 4 of the students. They came up in a month later. They designed a system with 90% accuracy. I said, it's not possible. I gave it to two other students to do a check on it. They said it was fine. I should tell the drug manufacturer. I said no. I went through it and I found that the algorithm was actually cheating on itself. So, excuse me. So today we have a system where people have gone ahead and done it, but there is very little validation of it, very little updation on it. With neural networks and others, you have to continuously retrain the network. We are supposed to run with new population groups. Nothing of this I see is being done on a systematic basis. Nothing of it is being done at the government level in this area. We also find that in the area of healthcare, the normal checks and balances, most of the doctors are extremely good, very competent, very proper. But at the same time, we have some outliers who are creating problems. We saw it in the case of Larry Nasser and others, especially targeting the students and all. And there again, we don't find any proper mechanisms to really take care of the situation. I was asked by the Federation of State Medical Boards. I gave a keynote address. They requested me to look at this area more. We went around, looked at all the state medical boards, and we found that there's a doctor who's practicing telehealth who's been actually disbarred from 3 states of the country from practicing at all. And he has gone ahead and got a license from it. And under the new provisions, that person could practice anywhere in the country. And by the way, this Federation of State Medical Boards used to have a directory of all the people who were disbarred in the country until 2012. And based on pressure, and you can guess from whom, that concept of having a nationwide directory was dispensed with. So we are going to use telemedicine at a national level. We have to be willing and we have to be able to accept it. The Veterans Administration, for example, would not give information about it, saying it's a security and secrecy of the defense forces. Very recently, the Congress forced them to go ahead and do it. So one of the areas we're investigating right now in my group is how to use patient-reported outcomes and how can we use this as a means to really validate it. And if there's real massive outliers, not somebody just making a mistake or something, but somebody really have a long record, what can be done. And that I think is really needed. Otherwise we'll have major disasters. I remember in the case of 9/11 or after 9/11, they made a policy that only the pilot and co-pilot can have the key to the cabin. And there's a case of a Lufthansa plane where the pilot went to the bathroom and the co-pilot took it over. He had a history of mental problems, which were not known to Lufthansa because of privacy rights. And the person deliberately crashed the plane, and more than 200 people died in the plane crash. So once we have these electronic techniques, it also puts a responsibility on us to develop these things. And this is again an area where you would find great reluctance on anybody to go ahead and do it. And there will be great reluctance from the funding agencies to do it. In the case of the law paper, which I wrote, when I talked to the lawyers and others, they said, well, NIH gives money, NSF gives money, but none of them allows any of that money to be used for things which are of legal and policy nature. So really this falls between the cracks, and that's an area where we have to really do it. And we have to do it not on a local basis or a state basis or a country basis. We really need to think of these at an international and global level. And that's one of the ideas that I'm trying to say, that in order to make headway in this area, we really need to have a pop-up policy or procedures which apply across organizational boundaries and national boundaries. The next area is the area of knowledge management. And again, this issue comes up again and again. First, it came in the area of currencies. If you are invested in the US, you get connected to the London Stock Exchange, you want to do it. It was at the local exchange. Some of those things have gone away. At the time of the Grenada War, the same thing was there. The pilots in the air could not talk to the soldiers in the field. I worked as a PI to try to find ways to integrate that information. Way back in the 90s, we told at that time the same problem will come up in healthcare. Nothing happened at that time, and now there's a recent article in Fortune where it says over $50 billion have been spent on this area, and still there's no end in sight, and in fact, lives are being lost by that. So that's an area which we are going to use digital and telemedicine we have to care about. So I've gone over some of these issues and the deliberate information blocking, which is being done by some of the companies in this area, how it was addressed. This person who's recently, when the government tried to liberalize it, one of the persons with a leading company, she issued a public appeal that you should resist it, and some of the hospitals in the Boston area, they publicly went ahead and did it also to support that venture. So again, there is whole dichotomy, there is no clear mission, willingness to do it. And again, this really requires an international initiative like W3C or somewhere else, which I think should be coordinated by somebody other than a government of a country. The next area is knowledge dissemination, that there's so much glut of information. How do we abstract it? A pilot going on a bombing mission is giving the least amount of information. The rest of it is distraction. In the medical field, the things are very different. What is the role of TCS professionals? Can we really do it? And then the next area I want to mention is that at MIT, we have started this EICU collaborative, trying to get data at one point, trying to get all the work at one place. And in the area of telehealth, in the area of coronavirus, we have looked at a number of areas. One, we have looked at the area of patient diagnosis. Another we have looked at is the area of infecting other people, medical personnel and others. Another one we have looked at is the EICU, how we can make them work better, especially in crisis situations like now. I talked already about the telehealth intervention program. We have also drafted with MGH, Dr. Lee on there, guidelines for how to use telemedicine to look at patients who are suspected of being brain dead and concluding instead of having the patient to be brought. So those are some of the things that we are trying to do in order to facilitate the work in telemedicine and telehealth. So these forces, when a global crisis comes, it really leads to a change in the industry. Y2K, for example, led to major transformation in many industries, financial and others, but it did not do it to the medical industry as much, because medical industry is one of the few industries, is the only industry in the US which is using the metric system. None of the others use it, so there was less problem there, but still they were there. The MD programs in the western parts of the US, they all require a mandatory course of telehealth. The eastern states don't require such a course. And as COVID-19 is there, there will be a lot more willingness to look at international issues. We have countries in Europe which have already realized the problem. 20% of their population goes across national boundaries every year. They've tried to do it across national boundaries. We need to think about the same thing. I just want to answer questions which I'm usually asked in sessions like this. And one of the issues people ask me is why are the other countries more advanced? Why is the western part of the country more advanced? What's going on? And the answer to that question is that first of all, in the Western states as well as in other countries, there has been a much greater willingness of people in medicine, people in technology, people in business, people in law, public and policy to really work together to achieve this change. And in many of these states, it's a university which has taken the lead in doing this kind of change. When I was in Arizona, my colleagues from law, all these schools that I mentioned, they would work together. And actually, it was an incestuous relationship to some extent. My colleague, who was the Dean of Public Health, was also concurrently the State Commissioner for Rural Health. And that helped by having a very close relationship with the state government. So the state governments have actually worked hard to do it. The distances are large between people, and that's happened. When we look at Massachusetts, first of all, there is no public university which has all these schools in one place. The law school is at a different place. The medical school is a different place. They don't even have it. And the private universities are just not interested in this kind of work of trying to have people from different disciplines work and lead to some change. The emphasis which is given in private universities is much more being the expert in one field, being really the super bright person, the star of the field, not these kinds of work. So
Okay,
that's
Amar,
one of the disadvantages of the system.
Amar,
Yeah.
we do have a couple of interesting questions.
Okay.
One is, it says, thank you for your continued work on telemedicine. Are you seeing any increase in awareness of the need for accessibility support for people with disabilities in telehealth platforms, including the integration of caption streams and interoperability of controls for people who are blind?
Well, I think it's happening in two ways. One is it's happening a lot more in foreign countries, especially in European countries. It's happening. It's being done on a systematic basis. In the case of coronavirus, the things have been done much more on a short-term basis. So there's less willingness to do these kinds of things. We also find the models which have been used in other countries are different from here. Here, the model is much more that you go to a medical facility, and that's where telemedicine is done. It's much less as far as home is concerned. Anytime you have any kind of problem, you should really be moved from the home to it. I'll give you a personal example. My father-in-law was very sick, and he actually passed away a few months ago. And we had the same problem. He was sick, he couldn't do it. And they basically set up an EICU or an ICU at home at the place where there were two people around the clock, their equipment and all. And again, these are the kinds of things they do when a person is disabled and all, which they're very willing to do in these cases. And even then, the price was much lower than what one would pay here for basic healthcare.
Okay, we have a number of questions that have come in. Next one is, what do you think are the best hospital systems for telehealth right now? Would Kaiser Permanente be an example, or if not, who else?
Well, you're putting me in a conflict of interest situation. I did not want to reveal the name of the organization, and I don't think it's right for me in a public forum like this, where it's going to be put on the web as well, to really go ahead and do this advertising and all. The only thing which I would go ahead and say at this point is that don't just go by the advertising of a hospital or the marketing of it. If they're doing good work marketing, they also have very good lawyers, I can tell you that. So go more by other things, what people say, not by how much advertising the hospital does. And as we have gone through this study, we have found some of the so-called best hospital in the country doing absolutely disgraceful thing in this area. That's what we have found when we have gone through of records of different places.
Okay, good. Um, do you think there are cultural norms that might prevent telemedicine from taking off in the US? And if so, what might they be?
Well, I don't think it's cultural norms, because one of the areas, or one of the reasons why Arizona did so well is that when the Indian states were taken over by the US government, they had guaranteed them healthcare for life. And therefore, they found that getting work done related to telemedicine on Indian health could be billed as being aid given to the Indian health. And there were also some very disappointing things. When I went there, I was asked to do the IRB, the training again, and I said, I've already done it. And they said, no, 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 it has also for Indian thing. And we found that more than 10,000 women had been sterilized without their consent between the years of 1960 and 1990, that recently. So again, I don't think it's the cultural thing which is there. If the cultural thing is there, it's much more the attitudes of the doctors, the other people who are involved in it, who really have been telling historically, you really need to see the doctor. And they make fun when I used to talk about telemedicine, and they say, what is telemedicine? That's just for the lab. Real patients need to see real doctors. And recently, when I went for my annual checkup, the doctor didn't touch any part of my body at all. And I felt, why did I even have to go to a thing if all the things, the testing is being done by other means to it? So I don't think the cultural thing is from the population itself. It's more the system which is bringing the cultural value.
Okay, good. Amar, thank you for opening this conversation. Do you think the COVID crisis will impact cross-border telehealth and medical tourism in the future?
Absolutely. I This was again something which I did. I should tell you about 10 years ago, I wrote a paper which basically said that doctors and nurses also need proper sleep and at regular sleep. And one way to do it when patients are at night is to have the doctor and nurse be located in a different continent. So I published this paper in Journal of Clinical Sleep Medicine. I got fair amount of hate mail in response to it, saying that I'm a traitor to the country. First, other computer things have gone abroad. Now I'm also trying to sell doctors abroad, and this is really bad. I wrote an article about it in the Wall Street Journal, and again, there was a lot of nasty comments on it. One of them was saying that I went to the hospital, they couldn't find my medical record. They said it had been sent to India and it had been lost. I checked all the companies, and everyone told me the records are never sent across boundaries. It was all wrong information. And very recently, Emory University has gone ahead and adopted the model which I proposed. They've actually transferred some of their doctors and nurses to Australia. They work from there for several months, then come back to the US. They've still not started using local doctors. In the area of radiology, it's already being done for quite some years. Number of radiologists, they're all US trained, they all have US things. But again, the administrative overhead has been very significant. One of the companies called Nighthawk, which has radiologists abroad in Australia, Israel, and India. They have they have staff to make sure that the doctor is licensed in all the states of the US. And at one point, the number of people they had to make sure that the doctors were licensed in each state exceeded the number of doctors itself. That's the amount of overhead which was being incurred. Canada has a single license for the whole country. Is that the right thing? Is that not the right thing? These are some of the other issues that we had examined when I was in Arizona. We wrote how should accreditation work, how should licensing work, how should malpractice work. These are the issues which will come up, and again, some of the work which we had done at that time will become relevant. So the answer to yes is a very emphatic yes, that it will lead to much more things. It's already happening in Europe. It's already happening in Asia. We are the ones lagging behind at this point in this area.
Okay, we've got a bunch more questions, so you may want to focus on brief answers to these so we can get them all in. What are some of the existing gaps in telehealth platforms that would deliver the most improvement in its adoption and utilization? So what's missing at the moment?
The missing thing right now is the interoperability angle. Different hospitals and different systems have their own niches. They have their own empires. And if you're using telemedicine, you're going to go to different hospitals, different systems. And right now, the tendency is is to repeat the test, do it again. That is the biggest one. And if you go across national boundaries, it becomes even worse.
So this is a little bit like the problem that the unified electronic medical record was supposed to solve.
Yeah, the only reason is I would say it's a little different. The EHR is just one of the components. The pharmacy industry has its own network. If you want to go for prescription, again, there's a national system. They are not international system. If you're looking at research data, there's another one. So these niches are coming along. The IoT people are coming along. We really need somebody or some organization to really think of it as an umbrella organization which can manage all these efforts which are going on in the different islands.
Okay, great. Next, what type of companies or industries are looking most into telehealth and telemedicine, and where will this have the most impact in the private sector?
Well, I think one of the areas I gave you is when you have a certain need for it, night and all, which I gave, things where you don't, where you don't have the luxury of seeing a specialist in that industry. That would be the one. The surgery one is the one which is going to be a little delayed. I think there are a number of areas, and again, in my latest issue of my journal, we've actually looked at some very novel areas where telemedicine has been used, and I would just suggest that you go to the web. The journal's name is Telehealth and Medicine Today, and look at the latest issue, and you'll find examples of what's being done in other countries. If you use even half of those examples, we'll be in a good way in this country.
Great. Okay, another question. Thanks for the talk. Very interesting topic. Given the shift from fee for service to value-based care in the US, can you comment on how telemedicine would play a role in value-based care?
I think we have to be careful about it. If the idea is to reduce the amount of cost which is involved so that somebody can make more profit, it will really bias the system, and I don't think it's the right way. And I'll give you a very specific example. I was in New York, and one of the hospitals there, I went and visited them, and they basically said they're not interested in telemedicine and all. And about 3 months later, they contacted me and they said that they want me to help them with telemedicine. And I said, what happened? Oh, we only want to use telemedicine for the first 1 month. Anything happens there, we want to use telemedicine. After that, it's totally useless. And that's essentially because of the way that if anything happens in 30 days, the hospital is responsible for it. So this kind of piecemeal kind of an approach where you're trying to optimize it and trying to let the operations research people go ahead and operations management people optimize it, I don't think is the correct way of doing it. If it's done with the right attitude, with the right mindset, then whether it's paid by fee, whether it's paid by value added, whether it's paid on each system, foreign countries, for example, are having a dual system. And in many of these countries, they're finding telemedicine is so inexpensive that people are using telemedicine instead of the government system. In some cases, the governments are doing it. And people have started all kinds of novel ways. One country, you don't even have to pay for it. You use the cell phone phone company reimburses the doctor for it. So those are the kind of innovations we should see. We should not be driven by the cost and profit orientation in it. That's my viewpoint.
Got it. Okay, great. Thank you. Last question. There's a lot of work happening in tech startups to enable and accelerate telemedicine. Given the new environment with COVID-19, can you comment on how you think technology startups can help accelerate this transformation? Specifically, what categories, either specialties or types of organizations, could have the highest impact?
Well, I have a viewpoint which is really somewhat cynical, and I would when long time ago, I tried to motivate people to go into the personal computer business, and I went to an IBM lab and I was told on my face that we are not in the toy computer business. If you want to deal with toy computers, go to apples and oranges. And I wish I'd taken that advice and gone to Apple. But after that, I was treated with great respect. And by the way, I've shared this anecdote with IBM people and they laugh on it today. So that's why I'm going ahead and saying it. And later they gave me a lot of grant money and they've been great supporters of it. When I look at the telehealth industry and the telemedicine industry, I do not find anybody here in the US and the countries I've dealt with more in the Western world who has really the ability and the will to really go ahead and form a massive global network or infrastructure which can do this. And I feel we need some leadership. In the old days, IBM provided the leadership to the computer industry. Right now, all these different companies are coming in and they spend a lot of time, they have a lot of good ideas. But unless we have a synergistic way of really taking all these pieces to add, a lot of this will be wasted effort. When the consolidation stage phase comes out, they'll all go out of business. So right now, there's no good way, and that again is a way where some industrial park or some innovation park affiliated with a university can play a major role in terms of laying the guidelines, or it could be somebody like Bill Gates Foundation or someone can do it. We do not have that mechanism at this point. That's just my reading of the situation.
Okay, great. And we're just about out of time. And I think that's it. So I think what I'll ask you to do is by now the new normal for indicating approval. If you go to your reactions thing at the bottom of your screen and give us a clapping hand or a thumbs up, we can see those on the collection of thumbnails. And you're getting a large number of claps and thumbs up,
Okay, I
Amar.
do
So
want to add one thing which I would say in response to the last question. I say, especially at MIT, and the bulk of the audience here is from MIT, I want you to encourage you to do this kind of work, to be the forerunners, to be the front people, really like the cowboys exploring a new area. I did the same thing on my check processing area, try to encourage the people to think, even when people were saying, why are you doing this and all. And people were very skeptical when I said, money is not the only thing, you should do it because you should think of whether you leave the world a better place than you come in. And people were again skeptical. But after this all happened, one of my students went ahead and started a company in the same mode. His name is Salman Khan, and he started Khan Academy, made a major change. So again, here, if any of you have any questions, further questions and all, feel free to reach me through email or other means, and I'll be happy to give you my advice. A lot of my material is on the web. And if you want to publish anything, I can help you also take it to the right authorities or right journals, not necessarily mine. With that, thank you very much again, and have a nice afternoon and evening.
thank you very much, Amar.